Welcome everybody to the vestibular evoked myogenic potential meeting here with odometrics. So today we'll have two of us here. We have Trine, who's keeping me on schedule and keep the thing moving and on time. And I'm Jill Craig. I'm one of the product managers here. And you can see some of our other webinars we have at Odometrics at odometrics.com/webinars. A couple webinar tips and tricks for you. I'm sure you've kind of logged in and played around with the information on the side and your panels, but all of you as participants are muted just to help us reduce the background noise. It's possible to ask questions during the session on the side question box to the right in the menu bar. We'll do our best to get to all of the questions collected during the session. You're more than welcome to email any of your questions. There's my email address there down at the bottom. You might want to write that down, as well as Trine. You can email either one of us, and if we don't get to your question here, or we run out of time, or you have some questions that kind of strike you after the meeting, feel free to email either one of us, and we'll get back to you as soon as we can, and we'll collect them at the end. If you have any technical problems, you can write a message directly to Trine from the side panel, and we'll see what we can do to get them taken care of. So who am I? I am Jill Craig. I am one of the product managers. I specifically take care of the otoacoustic emissions and evoked potential products within GN Odometrics. I work in Denmark over here, and I live in the United States in Portland, Oregon. Today I am sitting in Chicago, Illinois, in our North America headquarters to attend some meetings here with the team here. But mainly I'm in Denmark and travel the world to work and train and work with evoked potentials and otoacoustic emissions. So kind of exciting. Today is really exciting. We have people registered for this course, over 100 people registered to learn more about VEMP, and from all of these different countries. So we have people wanting to learn more and more about VEMP everywhere in the world. So it's an increasingly exciting part of evoked potentials. So I think it's really exciting to have this many people and think that you're learning about VEMP. And so we have people from the very beginnings of wanting to learn the very basics of VEMP and cervical VEMP and ocular VEMP to probably some very, very experts in the field listening in today. So please feel free to ask questions. Please feel free to ask to repeat something. If something's not clear, we can discuss it in a different way. I know we'll probably have some language barriers as well. I tend to talk a little fast when I get excited about a great topic like VEMP. So please ask me to slow down or go back and review something. It's not a problem. So we're at all different levels. So let's work together to get through some pretty exciting information. Today we're going to talk about general VEMP overview and review. We want to get everyone on the same page. So today is a review session of some very basic information about VEMP. We want to look at the basic anatomy and physiology so everyone understands the premise of where this response comes from and how it happens, and then a very basic overview of results, what to expect with certain conditions and how it should look. And then when we understand the very basics of this response and where it comes from, then we can look at how do we get through a test, what we should do to collect good data, how we can avoid collecting bad data, and those sorts of things. But I think once we understand what we know, what we learned today, then we can move on to part 2 in 2 weeks. So hopefully we'll see who's here today come back in a couple weeks and grab the second part of this whole VEMP. We only have 30 minutes, so we can't jam all of it into 30 minutes, but we do appreciate you taking the time to learn what you're going to learn today. I was going to have a question, and I'm probably not the expert on this webinar, but I was curious to know who that's joining today with regard to VEMP. If you consider yourself beginners or that you have some experience doing VEMP. And if you have some experience, whether you do CVEMPs, OVEMPs, and if you know a lot about VEMP, I just was curious with the people that are here, what you knew. And if you just go in that little chat window over there, and I can see that some of you are putting your answers in there. I don't want to kind of put everybody there or put you on the spot there, but I'll have Trine kind of take some notes there for us of who's doing VEMP, just so at the end of the meeting I can kind of collect and know how many people are at the various levels. It will help move along, it will help us along the way make better meetings at different levels with regard to VEMP, particularly the next meeting. And they seem to be stuck. Hang on just a second. Hang on just a second, my computer is, there we go. Okay, so let's do a basic review. And we know that VEMP is going to investigate otolith or vestibular nerve function. Not only that, but specifically if we look at otolith and the vestibular nerve function, the VEMP is good for those with a dysfunction characterized by a feeling similar to being on a boat or in an elevator or a lift. The symptoms are not usually characterized by spinning. So that when we talk about doing a VEMP on everybody, we don't need to do it on everyone that's dizzy. We need to really look at that patient history and the case file to know who to do it on and who not to do it on. We ask the right questions, we get the right information to know who to do this test on. So if that person describes that feeling, when they say they're dizzy, we need to ask the right questions to get these answers of how dizzy are they. Describe that dizziness specifically. We need to remember that VEMP is a short latency EMG potential, and it's evoked in response to a high level stimuli, acoustic stim. So if we don't have a loud sound, we're not going to get the response. And if we know that it's a muscle, we have to have a contracted muscle to get the response. So VEMP just doesn't happen. We have to have certain things in place to get the response. We have to have the contracted muscle, and we have to have the high level stim in order for the response to be present. The responses are mediated by the vestibular system, so we know that even if you have a hearing loss, you still have the response because it is the vestibular system that mediates the response. That's where it comes from. And VEMP provides us a quantitative, separate ear information about otolith and vestibular functions separately from any other test. So we're getting completely separate information about this. What are the clinical applications of VEMP? It provides us assessment with complaints of sound-evoked vestibular symptoms such as Tulios or superior canal dehiscence, that third window phenomenon that happens. It allows us the assessment of the saccule and the inferior portion of the vestibular nerve in different vestibular pathologies. So allowing a saccule and inferior, as well as as well as the assessment of utricle and the superior portion of the vestibular nerve. It's also really useful when we're assessing those receiving cochlear implants, particularly children. If we can assess the balance system with children before their cochlear implants, we can know after that implant, there's a percentage of children that come out of that surgery with some balance disorders. We don't know if they had them going in or it happened during that surgery. So if we can do a pre and post, we know the condition of the otolith organs prior to surgery. So it's becoming a more common test to do for implantees pre and post surgery to know the condition. So we know that those kids after surgery, if they are kind of have some imbalance, what the condition of the system was before surgery and after. And there's more and more data coming out, some really recent articles with regard to auditory neuropathy, concussion, and diabetes, they have some very specific responses with regard to VEMP, OVEMP, and CVEMP. So if you're interested to just do some Google searches on those three conditions and VEMP, and I think you'll find some pretty interesting articles. So some pretty nice emerging data and some studies out there. Very interesting. So let's do some basic anatomy and physiology. If we think about how the system works, and in general on the left, if you think that the body has to receive input, and then the brain has to process it, and then we send information out. So if we think that we receive information from the ears and our eyes and somatosensory, and the brain takes that information, processes it, and sends a message to the correct output. And that output with regard to our balance and staying upright are certain reflexes that keep us standing up and so we don't fall over. So obviously our brain is that central processing piece to keep us up. And if we think about the brain seeing an object, and then that nerve, the optic nerve, is going to send it to the brain, and then we receive information from somatosensory, whether it be temperature or things like that, and basically those feeling things. The somatosensory system receives input, and then we think about what we're more focused on, the ears or the otolith organs. So otolith senses motion. We have the saccule, and that's acceleration in the vertical plane. So think of an elevator or a lift specifically. You can see where the saccular macula is over here. And then you have the utricle, which is acceleration in the horizontal plane. So think driving in a car or running. And you want to look at those two pieces. So OVEMP or CVEMP, so we'll think about VEMP testing in that regard, to testing the saccule and the utricle. And then we said we're going to receive that information at the brain. The brain is going to process that information and decide where to send out a message to the correct reflex. So the vestibular ocular reflex, the vestibular spinal reflex, the vestibular colic reflex. And what those reflexes do, the vestibular ocular reflex, which you're probably most familiar with if you've done balance testing before, is going to help us maintain visual acuity. The vestibular spinal reflex is going to receive a message with regard to maintaining posture and gait. And the vestibular colic reflex, the brain sends a message there to maintain head stability. So those three reflexes receive a message from the brain to help keep us upright. So those are the outputs received. So if you think about it in this very simple way, it sounds really simple, but obviously we're a very complex system, but it can break down to a pretty simple method of receiving input at the brain, processing the information, and sending it to the right output. But obviously if something breaks down, it's obviously disastrous. If we think about CVEMP, we have testing the saccule and the inferior nerve, and it's recorded from the sternocleidomastoid muscle, and it's an inhibitory response, and it's recorded ipsilaterally. And then if we talk about the OVEMP, and this is primarily utricle, and it's from the superior nerve, and that's recorded from the extraocular muscles. This is an excitatory response, and it's recorded contralaterally. And if you think about that same picture we just looked at before, we're going to talk about the green side here being the saccule and inferior portion of the nerve that we're testing when we test that saccule. And then the OVEMP, being primarily utricle, is going to be that superior nerve function testing this side. And I say primarily utricle because it isn't just the OVEMP that tests just the utricle. You got a little bit of overlap in there where you're going to get some saccular function that is also being tested. And then you can see that when we record, we'll talk more about recording in the next meeting, but for today we're going to just do mainly just anatomy and physiology things. But let's look at where we're testing or what we're testing. So if we talk about CVEMP, we're looking mainly at the sternocleidomastoid muscle, and that's that long muscle in the neck that goes from the sternum up through your neck up to the mastoid and connecting there. I think the tendency is people forget just how long that muscle is. Just a second here. Okay, good, sorry. I think we forget just how long that muscle is, and we'll really talk about it in 2 weeks with really putting the electrodes in the right place, because if we put the electrodes too high or too low, we'll actually get, there's the possibility exists to not get a recording at all. And we need to think about where it starts and where it ends, and actually putting that muscle in that middle third. So we should divide this muscle into 3. And I know that most of you are sitting there holding the muscle, your own muscle, right at your neck, and finding that sweet spot of where to put it. And then with the eye muscle here, the inferior oblique and that inferior rectus, when we run an OVEMP, to actually have that patient look up, and that's that contracted muscle. That muscle contracts then, or there, sorry, and that's what's being reported is the actual contraction of that muscle. So we want to make sure that we have them looking up, and just as you would contract that sternocleidomastoid, we have them look up to get a maximum contraction. Here's an example of this CVEMP and the OVEMP here. And when we look for the CVEMP, we got this nice big contraction here. We're looking for P1 and an N1. And we typically, there could also be called P13 and N21, purely from where they're located. And that's a generalized number of P13, meaning of somewhere around 13 milliseconds, or N21, somewhere around 21 milliseconds. And then when you look at an OVEMP, for example, we're looking for that N10, that it pops out. It's a contralateral response, and we can see that just at 10 milliseconds. Make sure I'm not missing anything here, sorry. Great. Great. Super. Wanted to make sure I wasn't talking to myself, sorry. Okay. Oops. Here, let's go over this pathway. I think it's really important to understand this. We're going to look at 2 similar slides, but I think it's really important that we understand when we look at these oblique muscles and we look at the right and left sides, that we think about this crossover or the contralateral recording to check that superior vestibular nerve in the utricle, meaning the OVEMP is that crossed over or contralateral response. However, when you are doing a CVEMP, you have this ipsilateral response, and that is the inferior nerve, and checking the saccule. So just keeping in mind and understanding that CVEMP is ipsilateral and it's an inhibitory response. OVEMP is that crossed or contralateral response, and that's the excitatory response. Here's another example. I think it took a long time for me to understand this, and I'm not sure why, but I think because there's so much going on the screen that it was a little overwhelming. But I think let's look at the left side of this first, and it's a healthy subject. So we know if we're recording OVEMPs, we've got the left is going to cross over, the right is going to cross over, and we have CVEMPs ipsilaterally. And everything should work out just fine, right? So we've got, here's our OVEMPs and our CVEMPs here. So we have beautiful responses. Everything's present. Everything is where it should be. We've got a nice N10 and we've got our nice CVEMP here. When you come over here and we knock out the right side, the utricle and the saccule, something doesn't work. We're able to see that the OVEMP doesn't work. That crossed response doesn't work. And then we can see that the ipsilateral right doesn't come out. So we're missing the CVEMP and we're missing the crossover OVEMP. So we can kind of make sense of how the system is working. I think when you sit and follow this through and remember the ipsilateral CVEMP, the contralateral OVEMP, you can make sense of where things break down. So the OVEMP crossed over, this doesn't work, and the ipsilateral CVEMP disappears. So what are we looking for in our results? And obviously we'll do a lot more of this in the next one, but just as a basic overview for things to keep in mind with your VEMP results and to be in a general results and on a high level. We want to look for an asymmetry ratio in CVEMPs. Depending whose literature you focus on, we look for an asymmetry ratio of 35 to 40%. And then we're looking for increased or high amplitudes, and those are consistent with peripheral disorders. It's pretty general. Latencies, delays in latencies are consistent with central pathologies. And then with regard to thresholds, decreased thresholds are consistent with peripheral disorders, generally SSCD. So if you're going to run down to 60 or 65 dB, depending on whose literature you pay attention to, if you get a VEMP at a level that low, you can be pretty assured that you've got an SSCD. That's a pretty cut and dry thing. There's also some literature that supports running a tone burst at 4,000 hertz if there's a presence of that SSCD. You could also see, be assured that that's going to be an SSCD with the presence of a VEMP at 4K. It's a little cheat sheet. I think that's kind of nice to just keep in mind that with regard to CVEMP, if you have a Meniere's patient, you should see reduced amplitude on the affected side. Just as I just mentioned with SSCD, they're going to have that reduced threshold of the CVEMP. With vestibular neuritis, because that's peripheral, they're going to have that reduced amplitude on the affected side, just like the Meniere's. With vestibular migraine, they'll probably have a normal CVEMP. And then with an MS or multiple sclerosis patient, because that's a central disorder, you'll expect, you may see that prolonged latency. And then with OVEMP, we're going to see that increased amplitude. With SSCD, increased amplitude, reduced thresholds again. Vestibular neuritis is going to be absent OVEMPs. Vestibular migraine, normal. And then with OVEMP for MS, we're going to see some abnormal OVEMPs. Let's see, I should probably go in and see if you have any questions, but as I also mentioned, you should feel free to email. That's going to be the end of part one, and I think that we want to, this is a good foundation for us to use to make sure everybody's on the same page so that when we start to look at data next week and start to think about how we prepare our patients, we want to make sure that everybody who attends is going to be on the same page and using the same terminology and things like that. Let's check here for 1 second and check our, yep, somebody wants to know the parameters for CVEMP and OVEMP, and we're for sure going to go over all of that next week, but we needed to make sure that everybody's using the same terminology. Next week we're going to talk, or sorry, 2 weeks, we're going to be talking all about the collection parameters and tips and tricks, setting the patient up to collect the cleanest data that we can. So next week, or 2 weeks, will be all of that information. The other question, let's see. Someone else asked about how do we collect, or is it possible to collect VEMP on kids or kids younger than 2? And it is. I'll see if I can put a nice picture or video of that in the next time. But basically what you can do is if you hook up the VEMP and just put a video either on your phone or on the TV and turn the child, actually hold the child facing out and turn them away from the video, they're going to turn their neck back to see that video. That's a pretty clever way to do that, and seems to work quite well. And just keep the video turned away from them, and they'll turn their face or head to the video, and you should get a nice contraction to do that. And let's see, I don't see any other questions there, but you can feel free to email after. And let me just check something here. And then I did, we had people who responded, just for your information, so you know who joined you today with regard to the knowledge question at the beginning and answering A, B, or C. Of the people that attended, 30% said they were beginners. 50% felt they had a pretty good experience or fair experience and knowledge level, and then 20% said they knew all their P's and N's about VEMP and were here to just see if they could learn a little bit more. So I think that's a great mix of people. I hope that you enjoyed what we did today, and next, in 2 weeks when we come back, do please feel free to email Trine or I with some suggestions. The plan is to do more data collection, tips and tricks to collect. What are the parameters? How do I do it? So that's the plan for 2 weeks. So we hope that we will see you then. And thanks for coming today and taking time out of your busy day to join us. We really appreciate it. And take care. Thank you.